Very good morning and warm greetings to all my esteemed faculty from France, my dear colleagues and students. Cancer requires multimodality therapy. I'll just first give a little glimpse of we have been just listening for last 1 hour, the various difference in the pattern of cancers. We just listened to the first speaker about the cancer patterns from France. Now, these are the 5 common cancers in males in the middle, lung being the common, like what you see there, oral cavity, esophagus, stomach, larynx, and I would like to add here, number 6 is now colon cancer, which is in the males, then also in women, which used to be 20 years back number 18. Now it has jumped to the number 6, both in men and as well as in women. So that's the major change which we have seen in the last 2 decades. Now, some of the patterns which we just Professor Rath mentioned to you. Cervix cancer is coming down in the last 2 decades from the various cancer registries. Breast cancer is going up. Prostate cancer is also on the rise. And ovarian cancer also slight increase. Interestingly, another major change which we have seen in this country in the past 2 decades, the lung cancer, though there is slight increase in the males, but in women, the lung cancer is on the rise. That's one. Interestingly, on the other hand, the mouth cancer, oral cancer is on the decrease in women compared to the males. That's another change. Esophagus cancer is on the downside, is coming down, but as you can see the slides on the bottom, both male and for the females, the large bowel or colon cancer is going up. So that clearly shows the type of the patterns, the diet patterns, or kind of changes which have happened in the past 2 decades. From number 18, it has jumped up to the number 6, which really has happened. So it's really kind of sociologists, social sciences, scientists really have to think how really to see these changes. The other interesting, which also tells us about like how a state is governed the best. Now this is one of the very clear example, like the cervix cancer. If you see here, on the right side, those who are literate and gone to the college, the risk of cervical cancer is very, very low compared to those women who are illiterate or uneducated, never gone to the college. So if a government provides good education, good social support, you're going to see some of these cancers going to go down. Now, another example, the oral cancer, again with education, those who are illiterate, they have the much higher risk compared to those who have gone to college, the risk is very, very low. Which is another example, so how these things can really make so much of difference in the incidence of these cancers. Chemotherapy, which we just listened, is one of the treatment for the last 5 decades and has provided cures in number of cases. This is one of those unusual tumors where you can get the germ cell tumor seen in 20s and 30s in young girls, where you can see the almost cure is to the tune of 90% and above, even include the advanced disease. Though unfortunately, it used to have some of the side effects, not only the bone marrow suppression, the GI toxicity, the alopecia, which most of us are scared, and even the oral mucositis. Some of these kind of changes, which are not, fortunately not, they are reversible or they do not last long. The good news is this, that in the past 15 years, we have now able to understand the cancer much better. We understand the molecular level, what are the changes which are happening, and as a result, we have now development of so-called the targeted, or you can really hit the exact molecular change which is happening inside the cell. But different to the cytotoxic chemotherapy, which I showed some of the pictures, some of the side effects like bone marrow suppression is generally not there with these, but you can have some of the skin toxicity, you can have hypertension, fatigue, which could be common problem. Or sometimes you can have these hand-foot syndrome where the skin can sometimes get erythematous or can, even if it is very severe, can peel off also. Now, the various mechanisms which you see, either tyrosine kinase inhibitors, which either because of the blocking the receptor or the ligand or monoclonal antibodies, which can lead to the blocking of these various mechanisms inside the cell and finally stopping the proliferation of cell and into the cell cycle and therefore stopping the growth. We have the first targeted agent, chronic myeloid Gleevec for chronic myeloid leukemia. Before that, let me just give you some of the glimpse how lung cancer, which is the common cancer in France or internationally in India too now, how it is different from the Western world. These are some of the patterns about the histopathology. We have adenocarcinoma almost 44%, 45% from two major centers from our institute and also from Mumbai. And these are some of the data about the mutation. Now, for advanced lung cancer, if you have this particular mutation on the exon 19 or exon 21, which is seen fortunately in Asians in about almost 25 to 50% of those cases, they can respond to this new targeted therapy called Gleevec, called gefitinib or allotinib. And these are some of the pictures, like the various techniques which have been compared to international data. The median progression-free survival in these patients is like about 7.5 months in our experience, and median overall survival 12.7 months. This was a limited series of nearly about close to 100 patients. Similarly, the breast cancer in India is different. I'm sure we are going to have a little more discussion on this. We have very small percentage of early stage, close to about 30%, stage 1 and 2, and the rest of our patients are stage 3 and 4. The major other difference is that the receptor positivity is in about 64%, which is about 10% down compared to what you have data from your own country. And we have more of triple-negative breast cancer, which is about 22%, about nearly 10 to 15% higher than what you see in the Western world, which is one of the high-risk category of breast cancer patients. At the institute, we normally use the immunohistochemistry, but you have these techniques also available, the FISH, which can be used to identify HER2 positive cases. The other example, I'll take you to renal cell cancer, which you see on the picture on the tumor in the kidney. And we have analyzed recently the data from our experience of about 200 odd patients. About 141 patients received the systemic therapy for metastatic renal cell cancer, either in the form of sunitinib or in the form of sorafenib or pazopanib, and some other combinations. And these are some of the results. The response rate lasted for nearly about 20 to 25%, both complete and partial response, which are more or less similar, both for the first sunitinib as well as the sorafenib or pazopanib. And the median survival of both PFS and overall survival being superior for sunitinib compared to the other agents. However, the number is small, but this is more or less similar to what we have from the international data. Now let me come to the first agent which was introduced for chronic myeloid leukemia, and this is the one drug which really has changed the management, the way we today treat it. The median survival for this disease of chronic myeloid leukemia, when we were students, we used to use hydroxyurea. Now, median survival used to be the hydroxyurea and interferon 8 to 9 years, but now today the median survival is expected to be almost 25 years. Many of the patients who were progressing in the early, before just 2000 years, fortunately, 2001, we got the GPAP program, Gleevec Patient Internist Assistant Program, which has been helping us. And we have now more than nearly close to 1,000 patients at our center, nearly 3,000, more than 3,000 in India, where this program is supporting these patients. And you can see the survival today for this particular disease is seen almost more than 90% of patients at nearly now 8 to 10 years follow-up in different places. This is some of the initial data from 400 patients, which we analyzed one of my colleagues from our place, with 96% of the complete hematological response rate, and with the survival of 96% at the more than 4 years follow-up at that point of time. However, this also has brought one of the difficulties, as it was mentioned, that some of the patients may stop therapy in between, may not completely have the adherence to the therapy because they think that they are now okay, they do not need treatment, and almost nearly in different series also from 25 to 50% of patients have been reported to not be so compliant because they take life very easy. It's just a pill once a day. So they feel that I'm okay, I don't really need this treatment. But if you see the data from our place, those who have not been adherent to the imatinib therapy, there the long-term event-free survival can be inferior, is inferior. So therefore it's very important to really educate such patients that they have to be strict to the compliance of this particular therapy. And some of the other regions, like even though we have the GPEP program, they have the free supply of the Gleevec medicine available to our patients, many patients still find difficult to travel such a long distance, coming from 500 miles or even longer, which may be one of the reasons that they find, and always one person has to come with them to really, when they visit to the hospital. And some of the, like especially the younger ones, they want to plan for their family. That could be one of the reasons. And those who cannot get this, we have fortunately now the generic brands or biosimilars available, which cost nearly about 4,000 to 5,000 rupees a month, which close to about 75 or less than 100 euros. But still many patients may probably find that one of the limitations may not be able to afford, especially some of the poor patients. Now, just to, before I end, let me just show you one of the major change, another hematological cancer like multiple myeloma. Though this is not so common, but in the elderly age group, this is the second commonest hematological malignancy after non-Hodgkin's lymphoma. These are the classic pictures of what we see in the plasma cells in the bone marrow, serum electrophoresis showing M-band, and lytic lesions in the skeletal survey. The drugs which have changed in the last 15 years, you can see in the second line and the third line, the immunomodulators, the proteasome inhibitors, and the recently in last 5 years, some of the drugs which have been approved, including monoclonal antibodies, which are now coming to the phase 2 and phase 3 trials and expected to be available in market probably next 4 to 5 years' time. They really are going to change this disease outcome or natural history as well. Some of them which we have been highlighted in the red, these are the drugs, the biosimilars are available in India, and it has been very fortunate for us that we are able to use these drugs for our patients routinely. That really has made a lot of difference. And as a result, today we talk of personalized therapy in multiple myeloma, because many patients, about 20% may come with renal failure, and you have a choice what drug to really use for them. Many patients who are elderly have history of DVT or thromboembolism, or those who are diabetics having peripheral neuropathy, you really can choose a particular drug of medicine which really to use, or those who have high-risk cytogenetics. They are prone, even they respond initially, but they are prone to relapse quickly. If you use them, the combination of bortezomib and dexamethasone, which seems to be one of the better combination compared to the other drugs. And as we have been able to start an autologous stem cell transplant program for last 15 years, and we have done about data for till about 2013 of 225 patients, and you can see the results from here for those who achieved the top line, the complete response. At the follow-up more than 15 years, we have the event-free survival of nearly close to 20%. 20% of patients, 22% actually in our study, have been surviving without and relapse-free for nearly 15 years follow-up, which we can call them so-called potentially cured, while overall survival nearly close to 40% in these patients beyond 15 years. This is something which was not really hard till about 10 or 15 years ago, till the transplant came in the picture and some of the new drugs which have made so much of difference. However, we need to remember India is a place which has a lot of arts. You have billionaire, which can match to Bill Gates, but you also have people like this. So we really have to, fortunately the All India Institute provides a lot of, it's like an oasis for such people who can really get the care, best care available anywhere in the world. And also we need to remember, we still have to depend, many of our people have to depend on these traditional healers in the remote site or the rural areas where you still do not have the so-called modern medicine has not been able to reach to those places. So with this, I like to end my presentation. Thank you so much.
Thank you so much. We have just time for one comment or one question coming from the audience, please.
Good morning, sir. I'm Sudeep Sen from the Department of Biochemistry. I thank you for your excellent talk. I had a question. You said that colon cancer, colorectal cancers have jumped from number 18 to number 6 over the last 20 years. Now, since the mutations or the familial things have not changed, so would you attribute it to changing dietary patterns, or what would you?
I think this is one of the change which most of us feel that probably the way our diet had changed in the past 2 decades or 3 decades, probably one of the major contributor.
So would it be a good idea to focus on metabolic targets to look at how we can treat or how we can look at colon cancer?
At least that will be one of the important parameters, whether that could be one of your prognostic point of view. I don't know whether for treatment point of view, whether we'll be able to find out anything, but at least from prognostically, this could be additional parameter which can be of help. Sir.
Okay, thank you so much, Professor Kumar, for this talk.
I just wanted to know, sir.
Sorry, no other questions.
No, just a small comment on what he has said, an extension, if you permit, sir. Sir, because it has skipped from 18 to 6th place, would you like routine cancer screening would include colonoscopy also, sir?
At this point, I'm not sure whether we really will be able to cope up with this kind of thing. The incidence, the age-adjusted incidence is about 4.6 for the men and 3.4 for women. So compared to many other cancers like breast cancer, which is about nearly 31 or 33, or cervical which is nearly close to 20, or lung cancer which is about 11 per 100,000, the incidence appears to be low, but compared in that table form, in order of that 5 common cancers, this is number 6. So at least in the high-risk patients, if one can identify, then this could be one of the which could be considered. Thank you so much.
Thank you so much, Professor Kumar. Thanks.
Thank you, sir.